Good afternoon, ladies and gentlemen, dear colleagues. I would like to share our experience with transapical approach, valve-in-valve, for treatment of structural valve deterioration of mitral bioprosthesis. This work is really teamwork that has been performed with real collaboration with the cardiology department, as you see with the co-authors. So just as a background, everybody here knows very nicely the new guidelines of American Heart, ACC, that specify that either bioprosthesis or mechanical valve is reasonable in patients between 60 years or 70, which is defined as recommendation 2A. And the meaning is that more and more patients we will meet down the road with bioprosthesis. However, everybody knows that bioprosthesis tend to deteriorate by the time. So within about 10 years, about 25% of the bioprosthetic valve deteriorates, and about 15 years, about 50% of the bioprosthetic valve will be deteriorated and need to be replaced. We know that we have several types of bio-valve failure, either calcification of the leaflet, tear and disruption of the leaflet, as you can see here. Sometimes we can see pannus or endocarditis or valve thrombosis, which is less common. So the gold standard, or the traditional gold standard of care for patients presenting with structural valve deterioration, is reduced surgical AVR. However, as everybody knows, many of these patients are at high risk for surgical procedure. Therefore, percutaneous implantations of valve device has risen as an alternative, very solid alternative for treatment of valve deterioration. So our objective was to analyze the midterm outcome of patients undergoing valve-in-valve implantation in bioprosthetic mitral position valve. So consecutive patients with symptomatic mitral structural valve deterioration using valve-in-valve technique via the transapical approach. Outcomes were rigorously assessed and reported based on the VARC2 criteria definitions. So we report 15 patients that the operation, the surgery has been performed, the cath lab equipped as a hybrid room. We used the transapical approach. The heart team included 3 senior invasive cardiologists, 2 cardiac surgeons, 2 anesthesiologists, 1 echo expert cardiologist, and of course technicians and nurses. We used the balloon Sapien XT. In addition, we have standby ECMO team for any catastrophic situation. So this is the table of the basic of the patient characteristic of our patient. Mean age 75. Most of them were female. Kidney disease more than 3, stage 3 was 7. STS score 10. Mean time from initial surgery was 10.6 years. Most of the people had, or 2/3 had predominant mitral regurgitation. You can see that the mean systolic pulmonary pressure was 69, which is severe pulmonary hypertension. Functional capacity was pretty bad. And here we specified the valve size. Most of them were 27, few 25, which is small one, and few of them were with a relatively large prosthetic valve. So we use the Sapien valve. In order to choose the specific valve for the specific initial bioprosthesis, we use the application in our cell phone. There is an application was written by Vinny Bapat from England, so we use it. And there are some possibility. You hit the application, the specific software here. You choose the valve, you have a screen that you specify the initial valve that the patient has. For example, you choose the Hancock 2, which is very common, and then you are being asked which size of valve patient has. In addition, there is some typical fluoroscopy of this specific valve, and also all the dimensions of the valve, and the recommendation which valve is the perfect for this specific bioprosthesis. For example, if you use the 27 valve, you are recommended to put Sapien 26. So we use the Sapien XT with the Ascendra implantation hardware, and this is two typical echo. This patient has valve tear, and you see eccentric jet of MR here, or severe MR with all the tear leaflet here that cause severe MR. From the surgical point of view, we use the transapical approach, typically fourth intercostal space. This is the head of the patient, the left side, the right side, the leg of the patient here. So what we do, initially we got the pivot perfect projection by angio, and then we put a needle above the chest of the patient, and we see in the fluoro the right dimension that we need to puncture from the apex. So we draw a virtual line, which is our direction of the puncture of the apex. And then we puncture the apex and perform the procedure. So in this way, we very easily can cross the mitral bioprosthetic valve with our guide wire, and then to put all the needed hardware. After the operation, after the completion of the deployment of the valve, we take out, of course, and close the purse string. Sometimes we use bioglue, sometimes no. It depends on the tissue of the patient. So this is a typical picture. The apex is here. This is the pivot view of the valve. You can see the hardware, and this is the typical deployment of a Sapien XT valve. Generally, we put one triangle of the Sapien above the annulus or the bioprosthetic annulus, which is between 10 to 15% above the old ring, okay, of the bioprosthetic. One more thing that we need to have, that we insist on conical or wedge position of the Sapien. You can see here, this is a little bit wider than here. This is the inlet of the valve. So in order to prevent migration of the valve toward the atrial side, so we call it conical or wedge position of the Sapien XT. So this clip demonstrates patient with double valve implantation. First, we performed the aortic valve, valve-in-valve, and then we inflate and deployed the Sapien XT in the mitral position. Finally, this is the final result. Patient who underwent double valve deployment of Sapien XT to the aortic and the mitral position. And this is the echocardiography of the final result. We can see no MR, of course, in TE. 3D reconstruction, real-time, demonstrates very nice view. This is during the implantation. You can see the Ascendra in the center of the valve. And here, you can see the implanted valve here inside the original tissue valve here. Okay? Let's go to the result. The composite endpoint of the device success was achieved in all patients. No need for additional dilatation. No more than equal or more to mild paravalvular leak. I insist on no even mild paravalvular leak. No apical bleeding. No need for intra-aortic balloon. No stroke. No re-exploration due to bleeding from the apex. One patient has been expired, died after 33 days from sepsis. During the follow-up, up to 5 years, mean 29 months, we have demonstrated survival rate of 86%, one operative, as I mentioned in the previous slide, and one patient, 1.5 years from non-cardiac reason, she had an abdominal tumor. All surviving patients were or are in New York Heart functional capacity 1 or 2. We have not defined any valve migration, no need for reoperation in none of our patients. Functional capacity from 3.5 preoperative to 1.8 postoperative. Change in pulmonary artery pressure was very significant. For 69 preoperative, dropped to 45 after the operation during the follow-up period, and a change in mitral valve mean gradient from 10.2 preoperative to immediate post-op 5.6 and 6.6 during the follow-up period. If we take the 5 patients with predominant mitral stenosis that presented with 14 millimeter of mercury preoperative, they dropped to 6.6 or 7.4 during the follow-up period. In conclusion, ladies and gentlemen, valve-in-valve for failed surgical bioprosthesis in the mitral position can be performed safely with high success rate. The immediate-term clinical outcome and echocardiographic result in this high-risk cohort of patients are encouraging. A residual elevated gradient across the valve were observed. This novel approach allows good survival rate and satisfactory quality of life during the mid-term follow-up period. I would like to thank the committee for the opportunity to present our data.